All right. Well, welcome everyone to this week's edition of It's Worth a Shot. Today is November 16th, 2022. And today we have some very special guest speakers in line for us. We will be discussing infection control assessment and response, lessons learned from the field per se, with a center spotlight on Sheridan Memorial from a small community in Plentywood, Montana, as well as discussing phase 3 updates, a special guest from the state of Alaska. Next slide, please. As always, thank you to all our speakers and partners and attendees. Next slide, please. And feel free to add in any webinar topics or ideas into chat. And same time, same place every Wednesday. And we do not have a polling question this week. Next slide, please. So with that, we'll take a quick glance at our weekly influenza snapshot. And unfortunately, kind of some bad news on the home front. We are continuing to see an increase in those influenza rates. And I will say that we're also starting to see that perfect storm that was predicted early on, where we're seeing a rise in RSV and COVID, some COVID respiratory mixture with flu. And with that note, I will also say that as they've been doing subtypes on the flu, they are identifying that the subtype is aligning well with the vaccine this year, which we all know that some years that's not the case. And discussions and data is showing this year it does have a pretty good alignment of that strain from influenza A is aligning with the vaccine. And also, I will say that the data from this week, this would be week 44 of the year, the observed influenza rates, this is the highest it's been this time of year, this week in the reporting period since 2010, 2011 reporting. So just a heads up, perfect timing still to get your flu vaccine. All right, next slide, please. So without further ado, I'd like to introduce our first set of guest speakers. We have Sherelle Anderson, the Director of Nursing, Holly Simonson, the infection preventionist, Kristen Vines, she is the resident care manager, all from Sheridan Memorial Hospital in the far north of Montana in Plentywood. Welcome, you guys. The floor is yours.
Thanks, Jessie, and thank you so much for asking us to present today. This is Sherelle. I am the Director of Nursing at Sheridan Memorial Nursing Home in Plentywood, Montana. Holly Simonson is our infection preventionist, and I think we're getting pretty close to a year for her. Quite a year it has been, lots of learning on her part and our part. And in the process, she got her master's degree, so that's awesome. And Kristen Vines, who is my right-hand woman and resident care coordinator, she's taking over the MDS as well. So that is about us there. I've been a DON just for a little over a year. So without further ado, we'll kind of go through a little bit of our lessons learned from our very first resident outbreak, which started in May of 2022. Can we go to the next slide? Thank you. So we actually were in the middle of an outbreak when state came to do a revisit with us from our first survey. And so we ended up getting a couple of tags in 880. So, and one of the parts of the DPOC was that we get an ICAR done and they suggested Jesse at Mountain Pacific. So we did do an online or a call type of a ICAR, and then Jesse actually came to the facility. We do have another one planned for January, and that they will cover the entire facility, which includes a rural health clinic and a critical access hospital. So our experience, just to let you know, as I said, this was the first time that we ever had any residents positive for COVID. And I had spoken with one of my friends in Wolf Point, and she said, once it starts, it's going to be like wildfire. And she was right. But we did have the perfect storm that weekend when it started. It was Memorial Day weekend. County Health was out of the building, basically out of reach. Our infection preventionist, Holly Simonson, was in Hawaii waiting for her grandbaby to be born. And basically we had Kristen and I. So there were a lot of things that we thought we had prepared, and our COVID plan was shot out of the water almost immediately, which is terrible. But that is one of the big things that we learned early on, is to be prepared all the time. And now we know how to be prepared. And I'll kind of let Holly go through some of the education that she's done, and just extra things that we did because of what we had learned through ICAR and through the directed plan of correction. We did do, and I started immediately on a apparent cause analysis or root cause analysis form that I was sent by our consultant at Billings Clinic. And it just helped us to kind of remember, what did we do and what day was that on, because everything started to melt together. The things that we changed, I guess, from my perspective, we did do a tabletop exercise with multiple entities in our building and discovered some roles that other people outside of our actual main, like, long-term care part of the facility could do to help us, because there were a lot of phone calls, emails, and I kind of had to set up, COVID Central Incident Command in my office at that point. So just a little bit about things that we changed. We did add a brand new COVID plan. We've gotten some other large items taken care of. We've gotten more PPE units because we ran out very quickly. And I believe that our plan at this time is a lot better than it was at that time. And just to let you all know as well, most of our residents, in fact, I don't have the exact percentages, but Holly does, most of them were vaccinated and had their first booster. We had not given a second booster yet when the outbreak started, but we did give the booster to 10 residents. 2 of them were positive the next day, but the other 8 stayed negative. So that is a good thing. We also have a high, and Holly will share that, the high percentage of our staff are also vaccinated and boosted. I guess I'm going to pass it to Holly and let her share a little bit about the things that she's come up with after the fact. And I know she always says she felt guilty. Well, nobody should feel guilty for getting to meet their first grandchild. So we'll send it over to Holly.
Thanks, Sherelle. Could we go to the next slide, please? So Sherelle covered kind of the scenario that we were put into, and really this was started on a long weekend with most of our leadership out of town, out of state, and it was really kind of a skeleton staff as far as getting any extra help into long-term care to handle all the different tasks that needed to be completed. And so one of, Sherelle talks about the tabletop that she put on to bring different departments together to really be able to outline and delegate tasks for each area that needs to be taken care of when this occurs.
Hi, Holly. This is Miranda. You're getting a little quiet. Could you maybe get a little closer to the microphone?
Yeah, I'm sorry about that.
No, not a problem. There you go. Thank you.
Okay, sorry about that. So Cheryl kind of went over what happened on that and some of the changes, you'll see listed on this slide that have occurred since the outbreak that happened just through the root cause analysis and the tabletop meetings that we had to discuss what we could do better. And then through the ICAR process, when Jesse came out to kind of review the processes that we had put in place, she shared a lot of resources, and we've kind of moved on from there. And I think all of these have been implemented now. It took a little bit to get like our new med cart to figure out cohorting, to create a COVID unit in a very small, limited space facility. Could you go to the next slide, please? So how we came about with the ICAR is when we got the F8A tags, part of that plan of correction was to work more closely with our state departments. And one of those is the Mountain Pacific Quality Health. And being newer to the IP position, it's taken a little while to kind of get up to speed on the different departments that are even available, how I should function with them, expectations from both ends. And so Jesse was great to kind of walk me through the process and what needed to be done. Part of the plan of correction was the CMS gave a referral because we were in outbreak with such a large amount of our resident population. And Jesse contacted me. We did a virtual assessment just through phone interviews, a lot of questions. I'm not sure how long it lasted, but I'd say approximately about an hour, where we reviewed a lot of policies, procedures, our vaccine rate amongst our resident population. At that time was just over 90% of our residents were fully vaccinated and boosted. Our staff population was at 81% at that time. And so we felt like that was covered pretty well. We had the tags that we got for the F80 had to do with hand hygiene, donning and doffing, some breaks in cross-contamination between PPE use in double occupancy rooms. We looked at linen and waste management issues, as well as preparation and maintenance of a quarantine isolation room. So she focused on processes, policy, procedures around those things. And then we ended up scheduling then a full ICAR later with her to go over that. Could you go to the next slide, please? Yeah, so plan of correction, we started with the Mountain Pacific. Jesse came out and did that. We do have, like Cheryl said, another one scheduled through the Montana DP HHS, and that will cover our full facility. So they've been good to coordinate days to do the long-term care, as well as the rural health clinic and the critical access hospital portions on that. Can you go to the next slide, please? So during the ICAR, Jesse came out, we did introductions. I'd say from start to end was about 2 to 3 hours. We sat down and kind of did an interview process to go over the tags that we had, where we were at with our audits for all of the tags, our vaccine program. We talked about leadership in our vaccine program and how we got our our rates up that high. We walked through the hallways, the storage areas, utility rooms, therapy rooms to review all of our processes, how we clean equipment, where our PPE is stored, how staff can access it. It covered pretty much all areas and got into a lot of detail. And thankfully, Sherelle and Kristen and I were able to accompany Jesse for all of that. Can you go to the next slide, please? So this is kind of just a summary of what was covered in the interview process. And we did get a like a formal printout of Jesse's results from all of this that covered these. So they did also go into how we, how Sherelle and Kristen communicated their processes for.
Sorry, Holly, can you speak up one more time? It's starting to get quiet again.
I'm sorry. Went through the processes from how and who is in charge of communicating with the community and residents and family during an outbreak, to what that plan is, who's in charge of each different area, all of the policies and procedures that are covered in our CMS guidelines, supplies, audits, even our HAIs, how I'm doing the surveillance for those, what type of reporting I'm doing, where are those reports going to. Covered quite a bit of areas, and actually it was really it was a really good review, and the feedback was good on some areas that I needed to work on and make improvements in. Can you go to the next slide, please? So I'd say the biggest lessons that I learned was to prepare better. Being new, you don't even really know what to prepare for or how to really prepare. I would say for me, my office, learning really to lean hard into our state partners and utilize them to help you prepare through just communications by emails for questions. But the ICAR was very helpful. I learned a lot from it. We have, like Sherelle went over, we have gotten our policies, our procedures, our flows to hopefully align well so that we're prepared, for the next outbreak. Some of the things Cheryl kind of went over before that we have done since then. We have a list of kind of roles with tasks assigned to those, so that if it happens again on a long weekend or when we're really short leadership, that those can be put out to the employees that we do have here to fill those, anywhere from just even answering the phones, making family phone calls, restocking PPE, getting supplies to the unit, to even just bringing in water and food for staff who are under a lot of stress and not having time to really sit and take care of themselves. We have increased and worked with our purchasing department to rework our flow and how we stock PPE so that it's available on the unit itself, and so that our carts are always stocked and ready to go. We involved different departments and got verbal agreements that they would be ready to respond when the call came. We've been working just through some resources that Jesse sent, grant applications to improve our fit testing, our respiratory protection program, getting our indoor air quality improved upon, and improving our EVS systems to make that more efficient and up to standards with the CDC guidelines. Next slide, please. Oh, I should say on there, another good suggestion from Jesse was to add in a attestation form now with the changes that employees will fill out when they start new, or I just went through it with our benefits day, that they are aware of symptoms that they should not be coming into work for. They know the policy and procedure for how to address when they are sick and can't come into work, who to call, what to do, what the procedure is, and how it's followed up upon. So we implemented that annual paperwork and also some extra training on test collection for COVID, so that everybody is well aware on the steps to take for that. And and so that they feel comfortable doing that. Well, one of the areas that we focused on and Jesse really asked about was our vaccination program. And this, you know, I really, because I came in, I've just now been here a year. So Cheryl and Kristen really had this fine-tuned. I can't take any credit for this right now. All of our residents had started the COVID vaccine under their leadership. So I just try to kind of outline what we do here. But through Cheryl and Kristen's leadership, they really did utilize the full facility, the community, different departments to increase the awareness of the COVID vaccines, to coordinate efforts to get the vaccine here in the first place. We worked with county health, we worked with our pharmacy, we worked with different departments in-house, set up vaccine clinics during the week. In a kind of our dining room area was shut down at the time. We would pull in nurses from different departments to man that area with the paperwork, with the administration, with the recovery, watching that. And that's continued on. We've continued on partnering with our clinic to hold a weekly COVID vaccine and work through the steps to make it available Monday through Friday if necessary. We just did actually today had the USDA grant consultant come to our facility to do a walkthrough and look through all of the items that we had listed in our request for the grant, which included air duct cleaning to help improve our indoor air quality. Cheryl's ordered new suction machines. They got a new medicine cart so that we will be able to fully staff and stock a COVID unit plus our regular floor and not have to go back and forth with either one. We've got more PPE units coming. We've got carts now in all areas of the facility. Cheryl and Kristen took on when the new bivalent vaccine became available. Our residents received that as well as this year's influenza vaccine on the same day, and they had that well coordinated. We've included some extra educational modules to cover the COVID vaccines to our staff. Yep, we've got a process in place to be checking on with our maintenance to make sure our HEPA filters are in our units are up to standards and taken care of. We also looked at the EVS system to go to a, you know, the new system so everything's closed, contained, and our carts are considered clean and up with the color coding and no double dipping system that the CDC is suggesting. Can you
I
go to the
want to
next?
just bring up one thing too,
Sure,
that
jump in.
Holly added. This is Cheryl again, but we have huddle every day. And she comes to at least 3 huddles a week and does some form of education every week, at least 3 times with our staff, covering all PPE and, you know, hygiene, cohorting, you know, whatever subject we are working on. And so that has been very helpful as well.
Yeah, I find that a really useful tool to reach staff as well as any new travelers that come in, try to do some intensive sessions with them to let them know where the items are at and how to handle linen and waste in a new facility that they've never been in before, or what the expectations are if a resident gets put on isolation precautions and what to do at each stage of that. So yeah, the IPC interventions, yeah, staff communications, getting to those huddles, doing some one-on-ones when it's needed with new staff or new students or new nurses that are coming on. Definitely improve my audit schedule. That was an area that I was really lacking in. So improve that, kind of set a schedule for myself and expectations for putting together, you know, QA reports at a quarterly rate. We improved a lot of the isolation room preparation, linen waste management. I did a lot of signage so that all staff would have resources to refer back to when I'm not here, so that they can just go and grab those signs and those sheets and say, this is what we do in this situation. Next slide, please. Yeah, just some resources, and I think Jesse's going to drop some more in the chat. I know it's a lot of information to go through. I would say it's been a huge learning curve for me. I'm definitely in a much better place post survey, but also post ICAR with Mountain Pacific. It really was invaluable to kind of get myself up to speed and expectations of my department and how I can really function to support our frontline staff at whatever level they're at, whether it's our EVS department, our laundry, our CNAs, our nurses. So it's honestly been really great.
I want to also bring up, this is Sherelle again, that because Kristen and I were basically the only ones here, it was quite a bit of a nightmare at first, and maybe Kristen could say a couple closing items for us if she's available on here.
I guess the biggest thing would be, this is Kristen, I'm the resident care coordinator. The biggest would be that we thought we had like all our PPE ready to go and we had all our carts ready, and we found that we didn't have enough because we had such an influx of residents at the same time. So you're sharing, you're not sharing, you want to make sure everybody has enough for each cart. So that was just really difficult. I didn't realize how we thought, we all talked about it, we thought we were prepared, and we just weren't for that mass amount of positives at one time. The other thing too is our purchasing department was gone, so it's not like they could have helped us bring things to the unit. So then me and Sherelle, we did have a little help once it was past Memorial Day, of course, but during that first part, we kind of were doing all of our own PPE cart filling up. So that was a little difficult. And then just a lot of our testing all the residents, testing, and making sure. Just so many tasks and calling families, like we were doing every level, trying to get everything done at every level for everyone. So that just knowing that we could have had somebody else call families, or like, hey, you're in the call, you have 2 patients, can you go get us stuff from the purchasing department? Just anyone. We could have reached out to more people, but we didn't even think about that. We were just like, oh, we need to do this and let's go. So that was just, for me, I would totally do it different now. Even if we had another perfect storm, I would do it differently. So that's good to know. And you only learn that when you go through it.
Yeah, I felt like we were pretty prepared until we went through it. And then it didn't feel like, even though I wasn't present at the time, I came back literally the same day that state showed up, was my first day back at work. It felt like we were pretty prepared. We had all the policies, all the procedures in place. We thought we had things lined up. But going through like the root cause analysis, the tabletop exercises that Sherelle and Kristen put on were really eye-opening of areas that we really needed to fill and be prepared better in.
Right. And I didn't realize this. That's wonderful, Cynthia, that they use an automated system. We could certainly do that, or use a different one in the future, or try something that would be awesome. Trying to think if there was anything else that was super big at the time.
Well, thank you guys so much. A special thank you to your team at Sheridan Memorial. And if anyone else has any questions, or you guys think of anything, please feel free to drop those in the chat. It does look like we're going to go over time today, but I feel like we have such good information on tap here with some phase 3 updates from our guest speaker, Julie Jensen from the Department of Health in Alaska. So without further ado, Julie, I'm going to introduce you to the group, and thank you so much for being here today.
You are welcome. Yeah. So my name is Julie Jensen. I am from Alaska. Our office is out of Anchorage. We're a pretty small team of 8 people, and we all have to be versed in every facility type. So today I wanted to go through some of the long-term care phase 3 updates that occurred October 24th. I'm just going to turn off my screen here so I can move forward. So yeah, next slide, please. So I wanted to talk about the psychosocial outcome severity guide. There were some changes to this along with the appendix PP that has to do with long-term care, but today's focus is just the severity guide. The purpose of this guide, it's a tool that surveyors can use to help surveyors determine the severity of psychosocial outcome from identified specific F tags, but it can also be used to determine level of severity with regulatory groups like abuse and neglect or quality of life, quality of care, etc. It is not intended to take the place of the original scope and severity grid that we would normally use to ascertain the scope and severity of certain citations, but it is used in conjunction with that scope. So next slide, please. So there were some additions to the definitions or the clarification of terms on the first page of the psychosocial severity guide, one of them being the term for psychosocial. It relates to the interrelation between social factors and individual thought and behavior. It refers to the combination of influence between psychosocial factors and the surrounding social environment, which could be physical, emotional, or mental wellness. Psychosocial outcomes, i.e. changes in behavior or mood, can result from facility noncompliance. And it is the surveyor's job to determine if there's going to be any negative physical outcome or negative psychosocial outcome as well. Next slide. Okay, so this has to do with the definitions of possible negative psychosocial outcomes that can come from noncompliance. I just wanted to add real quick that they added the term for fear. They added fear to this psychosocial list, and it's kind of interesting that they put fear here. So my team actually went out on October 31st for a survey, and we actually cited psychosocial outcome from fear. So it was really interesting to have that new definition within our evidence base. It was kind of neat. Next slide, please. So if a resident's psychosocial outcome cannot be readily determined through the investigative process, so the reasonable person concept should be used. This concept can assist the surveyors to determine the severity of negative or potentially negative psychosocial outcome. When you think of to what degree or severity level would one expect a reasonable person in a similar situation to suffer as a result of noncompliance. This comes into play when your residents that you are interviewing or investigating can't speak for themselves or have debilitating or comorbidities that prevent a solid interview. So this is when the reasonable person concept would come through. Next slide, please. So with the phase 3 additions, under the instructions of the guide, they did add a couple of sentences here or paragraphs. If the psychosocial outcome is identified, compare the resident's behavior and mood before and after the noncompliance and any identified history of similar incidents. But when a surveyor can't conduct that interview, like I said, because the resident just cannot do a solid interview, it is really encouraged within the guide to actually interview other individuals who are familiar with the resident. This can be residents' representatives or families, the ombudsman, residents' direct care staff, medical professionals, etc. This may help determine psychosocial impact on a resident if they can't speak for themselves. Next slide, please. So when you apply the reasonable person concept, there are some changes or additions within the phase 3 new guide, and it talks about the presence of a given affect, which would be a behavioral manifestation of mood. If that present doesn't necessarily indicate a psychosocial outcome that is the direct result of noncompliance, a resident's reactions or lack thereof may also be affected by his or her pre-existing psychosocial issues. because many nursing home residents have sadness, anger, or loss of esteem. The survey team must determine that the negative psychosocial outcome is a result of the noncompliance and not a pre-existing condition for the resident. Next slide. So within the guide, it does talk about a couple of examples or situations where you might find pre-existing conditions. The blue is actually what's in the guide. The black here are just some examples of what those might be. So this has to be kept in mind when you're going through this process and investigating, because these can impact a person's ability to just function and have that psychosocial wellness. Next slide. So within the guide, there was an addition that encourages the team to consider a resident's position when they're in the facility. So the resident may consider the facility to be their home, where there's an expectation that they're safe and has privacy that will be treated with dignity and respect. And the resident trusts and relies on the facility staff to meet their needs, and the resident may be frail and vulnerable. Having these things and keeping these things in mind when you're investigating psychosocial outcomes can help the surveyor apply the reasonable person concept a little bit better, I think. And I'm happy that they put that within the guide to help us. Next slide, please. So I'm not going to go through every step of the severity guide. Everybody knows the severity levels as they investigate, I'm sure. But I did want to mention that psychosocial as well as physical outcomes are equally important. And it's our job to determine, you know, what noncompliance, we need to know the severity level, and we need to look at the highest level. And more often than not, physical harm might outweigh psychosocial harm. I don't know about your guys' teams, but within our team, it's kind of rare that we do cite psychosocial harm, because more often than not, there's a physical harm element that supersedes it. So it's something that you guys should keep in mind when looking at your severity levels. Next slide, please. So obviously we have our levels here, 4, 3, 2, 1. Level 1 is not an option when it comes to psychosocial severity. But I just want to mention that, you know, the phase 3 additions gave us much more examples of negative psychosocial outcomes within the levels. More examples of what you might see rather than what you might hear in an interview. I thought that was very helpful, and it helped us during our interviews with our citation that we did the week after this came out. Our citation had to do with the fear to file a grievance. We had the majority, I would say maybe 10 residents that had a fear of retaliation. And so we had to go through this severity guide, which was very helpful because of the new examples that are in there, to determine that there actually was a psychosocial outcome of fear to put in a grievance. And so we had to work within our team to develop the citations, evidence, interviews, et cetera, to try and get this on paper so it could be cited. Next slide, please. I did want to mention that psychosocial outcomes may result in any facility noncompliance with any of the regulations, with any of the F tags. This also includes psychosocial outcome resulting from a facility's failure to assess and develop an adequate care plan to address a resident's pre-existing psychosocial issues. If there's psychosocial issues for PTSD, depression, anxiety, et cetera, and other examples that were in the guide, if they don't care plan for that, it can lead to continuation or worsening of the condition. Within the new Appendix PP phase 3 additions, they added a tag, F699, under the regulatory group of quality of care. This is for trauma-informed care, which I think is amazing. My background is psych, so I'm really excited that they put this in the F tag regime here. But anyway, they added F699 to the severity guide. As far as the list goes, there's a list in the back of the guide that kind of gives you the most susceptible F tags for negative psychosocial outcome. Even though you can cite it within any F tag, there's a list on the back that kind of gears you towards ones that might be more susceptible to it. But yeah, next slide. I think that's all my presentation. And it was kind of quick, less than 15 minutes, but I didn't know if anybody had any questions about that. Next week, yeah, I'm going to be doing the phase 3 updates from the appendix PP, talking about additions. There was a tag or two that were eliminated and combined with others, and a couple other things that we found during our course of using the new PP in our most recent survey. We had a couple of hiccups along the way when we were learning the new way of doing things. So yeah, that is pretty much all I got. I hope it wasn't too fast or too confusing, but yeah.
Thank you, Julie. I appreciate it. I appreciate everyone that's kind of hung on as we've gone over. Julie, I have a question for you.
Yeah.
So with that new addition that refers to fear, and you said you just had to address that on a recent survey, was
Yes.
that difficult to identify and confirm?
It was very difficult. So our initial red flag that came up was that we had a team of 3 surveyors, and each one of us during our process of doing the sample selection, you ask those general questions, how do you like it here? Are the staff nice? Do you think that you're being treated well? Do you think, do you think you have a voice here? When we ask those questions, do you have a voice here? Or are you able to have your needs met? Or are you able to share what you're having problems with? All 3 of us had residents who kind of shut down and kind of closed off and said, things can get worse if I do that here. That was the general list. The general gist that we got was things will get worse if I do that. And so we started probing that, what do you mean it'll get worse? What is there something that they're doing or saying to make you feel uncomfortable? And none of them would talk to us. It was kind of like, well, you'll have to just look for that. I don't want to talk about that. One of my gentlemen that I was actually interviewing personally, he said, I don't want to cause troubles here because I have nowhere else to go. And I was like, well, do you have the impression that if you do cause trouble, or you voice your concerns or your complaints, that you might not be able to live here anymore? And he actually physically turned around and put his head down and said, I think I'm done talking to you now. And so after we did our initial sample and we all sat down to do our final selection, each one of us had one of these kind of experiences that was like, this just doesn't sound right. It's a red flag in our mind. What does this mean? And so I actually did the facility task for resident council, and I asked to see the resident council. So I met with all of them, and I got more specific in the resident council. I asked them specifically, if you file a grievance, do you think that somebody might retaliate against you? I had 8 people in that resident council, and 5 of them said yes, that there would be retaliation. So I kind of went down the track of, what does that mean to you? What does it look like? So that's what I wanted to get. I wanted to get specific examples of retaliation. What would happen if you did this? So there were specific examples of call lights not being met immediately, or poor eye contact, short with them. One had a fear that their motorized wheelchair would be taken away. It was kind of vague. Like you have to take things that residents say with a grain of salt. It's one side of a story, and there might be more to that side of the story. But when I got some more specific examples, I actually went to the grievance officer, talked to them a little bit about how do you prevent retaliation here? What do you do to ensure that retaliation is not happening here? And there wasn't much that the facility did to oversee or make sure this didn't happen. The feeling from the residents was the retaliation was happening from the CNAs, from the nurses, from administration, all the way up to the grievance officer. I got comments during resident council that the grievance officer runs hot and cold. Sometimes she's mean and she's retaliatory. Sometimes she's nice and she's helpful. And then there were other instances where a couple of residents attempted to talk to a different person in regards to concerns, and they were always redirected back to the grievance officer. So there wasn't another avenue for them to go. So when we sat down to write all the evidence, we had a lot of interviews, concerns from them. We had an interview from a CNA, and based on their policy and procedures as well, which it says right in there that they have to not be retaliatory, And within their policy, it also has the verbiage that they shouldn't be afraid or have fear to speak out. So it was an interesting learning experience for us. And we're actually, as a group, we're meeting on Friday to talk about it with the rest of the team because there's only 3 of us there. But it did develop into something. And those little red flags that you get when you do your initial interviews is it's not something to be ignored.
Well, thank you, Julie, and thank you for sharing that experience, and thank you for kind of touching us off with the first sneak peek on phase 3 updates. And we definitely look forward to hearing from you next week as you have the full 30 minutes to fill us in.
Okay.
So again, a special thank you to our guest speakers. If anyone has any questions, feel free to shoot us an email or drop it in chat. As always, there's an evaluation link. Feel free to complete that. And same place, same time next week. Take care, everybody.